Don't trust him. It was so good.
So funny.
And then it was like HIPAA violation.
Oh yeah, because you were doing the total gym. Yeah.
HIPAA violation. Okay. All right, let's hit that again. We're on. We're good. Okay. And you got all the anterior stuff, right? You got all the anterior muscles on the spine.
Up on the thing?
Yeah.
I think I did.
Or did yeah, here there. Yep, cool. Okay, cool. So let's so we talked about the QL, the quadratus lumborum last time. Do you guys have any questions on that? That big old slab of muscle that kind of connects the ilium to the rib cage? No, we're good there?
Yeah.
Okay. When do you use your QL? Hiking your hip, raising yourself up from a side-lying position, so heavy lateral flexor, and then salsa, tango, and ballroom dancing. Okay.
It's a lot of hip hike.
That is a lot of hip hike. Okay, so abdominals. We have rectus abdominis. I wish you grabbed Skelly for these guys.
Yeah.
You got that?
Yeah.
So we have rectus abdominis, external oblique, internal oblique, and then transverse abdominis. Sweet here. Which finger got blown out there?
I don't even know if
That
it wasn't
wasn't
a finger. I
fingertip.
just a piece of something.
Maybe a little bit of patella just got blown off there. In surgery.
Well, alright.
He's falling.
He's getting old.
It's well used. We'll have to put him up for retirement here soon. It's like losing some cartilage here. Ligaments. Take some beads and shit. Man. Okay. So yeah, we have the four abdominal muscles expand far beyond the stomach region. In fact, they form a muscular girdle that reaches around the sides of the thorax to the thoracolumbar aponeurosis. Okay, so thoracolumbar aponeurosis.
That's that big sheet on the back.
Yep. Superiorly to the middle ribs and inferior to the inguinal ligament. Inguinal ligament? Down here. Yep. And then we have linea alba right here. And then what is it? Is that the aponeurosis as well? Yeah. They
That's
call
like
it-
over.
They call it, yeah, the kind of the sheathy thing is the abdominal aponeurosis there.
all the way up to here.
Yep. Yeah, up to the, what is that? Up to like the 1, 2, 3, 4, 5, 6th rib. So kind of here-ish
Yeah, okay, attention's right here at the.
to the xiphoid. Yep. Okay, the immense span of these muscles with its unique overlapping arrangement and varying fiber directions helps to stabilize the entire abdominal region. The revered washboard belly is formed by multiple superficial bellies of rectus abdominis. Lateral to the rectus abdominis is the external oblique. Unlike the round bellies of the rectus abdominis, the external oblique is a broad superficial muscle best palpated at its attachments to the lower ribs. The thin internal oblique fibers are deep and perpendicular to the external oblique fibers and can be difficult to distinguish. The transverse dominus, the deepest muscle of the group, plays a major role in forced exhalation. It can be specifically it cannot be specifically palpated, right? When do you use your abs? Sit up, belly dancing, okay. All sorts of fun stuff like that.
Belly dancing.
Yeah.
Navy SEAL sit up.
This is interesting. The organs of the upper thorax are protected by the rib cage, while the viscera of the lower thorax rely on four abdominal muscles for support protection. The four abdominal muscles wrap the entire abdomen in vertical, horizontal, and diagonal directions. In the same way, packing tape is wrapped around the box going for a long journey. Okay, thanks guys. Okay, so rectus abdominis. So you guys are already looking at, okay, this is good though. Yeah, you're seeing them. So rectus abdominis, origin, pubic crest of the pubic symphysis. So where's that at? Solid. Nice. And then the cartilage of 5th, 6th, and 7th rib and xiphoid process. Yeah, yeah, just running up here. So what plane is that gonna move the body in based on the fiber lines there?
Sagittal.
Mm-hmm. Yep. And then, well, we'll look into this a little bit, but it could also do some rotary flexion if you're
One side.
targeting a unilateral component to this thing.
Yeah.
Yep. Okay. Cool. And then we can just see what this looks like.
Yeah.
So that's driving spinal flexion, rib cage compression. It's going to pull the ribs downward, forward. So that's moving everything in the sagittal plane there. Okay. Any questions on that? No? Okay.
Yeah.
External oblique. So the origin, external surfaces of the 5th through 12th ribs. External surfaces of the 5th through 12th ribs. So 1, 2, 3, 4, 5. 2, 3, 4, 5. Okay. And then what that's doing is, the insertion anterior part of the iliac crest, abdominal aponeurosis to the linea alba. So it's kind of running here. All right, and so it's really important to understand, and we're not testing muscles, but it's important to understand what this muscle does from a rotary standpoint. So that external oblique, based on the way that fiber line is running, is going to pull the rib cage down and the opposite direction. It's a contralateral rotator. So that muscle fiber set is going to help pull your spine in the opposing direction.
Right.
The cool thing about this, we'll look at the internal oblique now. So that internal oblique, origin lateral inguinal ligament, iliac crest, thoracolumbar fascia. So that's running back here. It kind of spans the ilium and then comes up into this stuff here, right? Into the internal surface of the lower 3 ribs, abdominal aponeurosis to the linea alba. So it's going here. So when it contracts, ipsilateral, same side rotated, right? So it's really nice to have these two oblique fiber sets because it's almost, those Chinese finger trap things
Right.
that creates this abdominal pressure system, which almost allows you to expand your spine when you contract them at the same time because it's almost doing the pulling apart without doing the pushing back together. So it gets this elongation of the spine and then also helps to counterbalance as you're rotating so that you don't rotate like this. Okay, so it keeps you up as you rotate if you access all that tissue at the same time. So you'll see people when you're doing some positional testing on spinal rotation, you'll see this sometimes, right? So if somebody's doing this, if somebody's doing this, right, and you're like, rotate left, and they're like, how did I do? And you're like, well, that's not really, you're side bending, right? So what does that? What could that mean potentially? If you like rotate, and they're like,
So they're
if we're thinking about just
are on, but their internal obliques are.
So we think about both obliques are lateral flexors, right?
Yeah.
Right, and then the opposing oblique or the opposing external oblique is a lateral flexor and opposite side rotator. So if they're doing this,
Oh, I see what you're saying.
I'm going, okay,
Opposite
maybe
side
there's
is
some
not- yeah.
right. I mean, we could just say lateral stabilization, but if we're talking specific muscles here, it may be that external oblique on that right side isn't coming to the party for them to stay on plane as they rotate, right? It also could just be the lateral stabilizers over there too, but I'm just talking in terms of the oblique there. That's a good possibility that there's some dysfunction going on with the thing that keeps them anchored to pull through there, right? And then you could also, I mean, this is the cool thing about, you know, looking at all this stuff is you can go, okay, I want to see, you know, can they maintain, well, we'll get into the testing in a second here. And then the transverse abdominis, the origin, lateral inguinal ligament, iliac crest, thoracolumbar fascia, and internal surface of the lower 6 ribs. So this thing kind of wraps the whole torso, and then the abdominal aponeurosis to linea alba. So kind of running in here. And so that we kind of had sort of an epiphany when Greg was here, when we were going through our advanced course. In the MAT, when I was doing MAT, they were talking about this TVA as like this heavy rotator. It doesn't really mechanically rotate the spine very well. And as we started kind of looking into this and exploring a little bit more about what it does, like this says, it compresses. So it's funny, we were doing this TVA test, like approximating the pelvis, and I was like all obliques basically. So that was, you know, something that MAT kind of dropped the ball on there. But one thing that I've been looking into and exploring a little bit with this is the vacuum component of it, which is actually a really important thing to be able to do for somebody, because it's actually like the true access of the TVA. I mean, yeah, I'm sure you can.
Which is hard to do, huh? I mean,
Yeah. So that what that feels like, and this should be part of our assessment, you know, going forward with people is like, can you vacuum everything in, and so you can have somebody push here, which helps to leverage that. It gives you a little more, I don't know, just a little more control there. Or starting hook lying and doing the hook lying where their spine isn't gravity loaded would be another way to do that. Can you guys feel that and access that?
Not as good as I used to, but yeah.
Yeah, it's sort of like you can like really feel the rib cage, like sucking
Yeah, so you should almost feel like there's a reverse shelf
it. Yeah.
under that like 6th rib there. Yep. Okay, cool. And then pyramidalis is kind of they kind of block this out as an additional abdominal muscle located superficially to the rectus abdominis. This is a small muscle. It's absent in roughly 20% of the population, but it tenses the linea alba. It attaches to the pubic symphysis.
Oh, interesting.
Yeah,
God, there's been
No?
like
I have no idea.
dude.
three muscles that we've seen that are not in part of the population. Was it psoas minor?
Yes.
And
Yep.
there's one other one too.
It was a knee muscle.
There's a quad, right?
Quad? No,
There's a 5th quad.
Oh, what?
Yeah. Yeah.
You're not talking about, because was it the knee flexor that we were looking at?
There's definitely one
quad?
knee extensor. Yeah.
What is
Yeah, I read an article, but I don't remember. I read it like a year ago or something. Maybe 1 year out the other.
Yeah.
It's like, oh, cool.
Yeah. Muscle, don't care. Was there one in the, was there a knee flexor, or am I thinking of the knee extensor?
I'm wondering if you're thinking of. Let's see.
No, maybe not.
Where is that?
Anyway, one of the ways that you can test pyramidalis, or test the system that the pyramidalis needs to work a little harder is this kind of posterior tilting of the pelvis and then extreme trunk flexion. And that's how you can get into that like really deep, low pelvic tissue there. It's kind of an extreme test that you can do on somebody, but it would be kind of this like tilty and super foldy, and then driving somebody out of that position. So we'll play with all that right now, because you can get that thing to cramp like crazy. We talked about diaphragm. We're good there. You guys are feeling good on the diaphragm from when we covered
Yeah.
it last week. Okay. Oh yeah, we're probably not getting into shoulder today. Oh, we might. Okay. All right, let's do some of this spinal stuff. Ow. Okay, so a couple things to think about when testing the spine. Do you want the person grounded, where they can use their feet to push into the floor, or do you want them off the tape or off the ground where you're forcing them to use more pelvic floor? Those are options that you get to think about when you're testing spinal mechanics. So you're going to get two very different tests from each one. Also, I think, this is the Bob story. The Bob story. Did I ever tell you the Bob story?
Yeah.
With the feet on the floor versus the feet off the floor.
Yeah.
So like, I think, were you here for that? I can't remember if you were here for that or not. But I was seeing spinal breakdown from Bob having his feet on the floor versus when his feet were off the floor, his spine was a brick. And so that's something that you have to think about too, is the relationship of that person with ground force reaction or the interaction with the ground. So, it's just as we go through this exploration of humans, you start to learn more stuff as you assess. And that was something that I found that was just kind of a crazy epiphany, was when he was interacting with the floor, his brain is going danger, stop, shut it down. And as soon as his feet are on the floor, his spine's like, oh, I'm good. I can do whatever I want to do. So we can, I'll show you guys some positions to work the spine in. So let's just start with rotation. And this is, you want to feel some of this?
Sure.
Yeah. Cool. So, make sure we're good to go there. Yeah, cool. You know what, man? Maybe do it. Yeah, just so it's easier to. Okay, so, and then scoot forward. Yeah, do you feel pretty comfortable there?
Yeah.
So when you're looking at spinal mechanics too, we want to make sure that they have stable hip flexion. So lift your leg up and push. Nope, push. Better there. Okay. So we can kind of make a decision on how we want to test the spine.
Should I be anchoring or no?
Nope, you're good to go. Ready, push. It's a little better. Go again. Ready, push. Yeah, so that's a little more reliable. Push up here. And you'll see this when you do the range of motion assessment too, like when you actually get them in for their range of motion testing. You'll see, like supine, if they can't get to 90 degrees, you probably don't want to be testing their spine at 90 degrees.
Right.
So, at 90 degrees of hip flexion. So this looks pretty good, but if you're just on the fly and you need to check it, this is a good way to do it. It could be interesting to see if you're potentiating or if it really is an issue down here. Lift up, ready, go. Yeah, so it is really an issue there. So
it feels weird just lifting my leg from that position.
you just feels dead, like blocked out.
Just feels sluggish.
Does that feel easier?
Yeah.
Ready, go. Yeah, so you got more there. Okay, cool. So so once again, there are a million ways to test spinal configurations. Go arms crossed. You can go arms above the head. You can go hands behind the back. You can go hands on the belly button. These are all decisions you get to make when you're testing this stuff. So there's no right way, there's no wrong way. It's just rationale, right? I kind of like to start here just because it's an easy. They're in their kind of anchored position. But if I want to test spinal extension with rotation, I'm not going to be testing them here. I'll be testing with the hands behind the head. Or you can test them here and have them go into thoracic lumbar extension and see what happens there. But anyway, well, that's going into the weeds there. So force coupling is the ticket here. And then thinking about moving them out of the position that they move into. So you can, what I like to do is go hands on them as they move after the first couple times I observe them. But first I'll go rotate right or left, that's fine. I'm kind of watching what his knees are doing. See, his pelvis is shearing all over the place, so he's not anchoring his pelvis super well. Go right again. So going right gets a little crazy down there. Come back to neutral, go left. Yeah, and left kind of similar too. So, so I'd say, hey, do you know how to do a pelvic floor engagement? Do you know how to do a pelvic floor engagement? Kick on the pelvic floor and then try rotating. So it shortens his rotary capacity, right? Go again. Do you feel like you can't rotate as far now?
Yeah.
Right, but your pelvis is not moving as much.
Yeah.
Go without the pelvic floor and rotate. is you get that little extra because your pelvis is going with you,
Yeah.
right? So if I wanted to test the pelvic floor stable and the spine moving, I'd say let's do the pelvic floor and then rotate right. Cool. Feel okay there?
Mm-hmm.
Yeah. And then the other thing
Keep it going.
what's that?
The pellet floor.
Yeah, let's keep that going. Come back to neutral. So then the other thing you can do is go with them just so you feel axially them rotating. So rotate right. So I'm like, okay, that feels pretty clean to me. He's not falling off. He's not dropping down. Okay, so this can be a semi-true spinal rotational test. Rotate. Cool. Stay there. Now I'm doing this force coupling. Maintain this position. I'm going to try and unspin you. Ready, go. Okay, no. Right? So there's that. Try it without the pelvic floor, just out of curiosity. Ready, go. A little better. Kegel, pelvic floor, whatever you want to call it. Ready, go. So, yeah, so that's something that so now I'm going, okay, is it your spine or your pelvic floor that's breaking down here? We could look at that. Yep. What are you
Pellet
doing?
floor?
Yeah, sure. Why not? Ready, go. And then no pelvic floor. Ready, go. Yeah, so it's just breaking down, right? So that's the rotary component. Then we can
Try it one more time.
yeah.
I'm gonna try that compression of the ribs. Okay,
Oh, that left
Yeah.
rib. Ready, go. Yeah, there it is.
That's
yeah.
great.
Let's try it on the other side too. We've been seeing he's got this like left rib cage compression. Ready, go. Yeah, it's a little better. Ready, go. That's quite a bit better, man. Yeah. Have you been working on that?
No, I haven't.
Oh, dude, you should just be
Just hammering on it.
just engaging it, not even compressing the body, just compressing that rib cage.
Okay.
That might help the neck too, man.
Yeah.
You might be all up here, and then
Mm-hmm.
trying to keep your head on plane, and that's
Right.
shortening all that tissue there.
Mm.
So
Try.
just keeping the body still and just compressing there. Yeah,
Cool.
because that's pretty dramatic
Yeah.
difference there, right?
Yeah.
Yeah.
What exactly are you seeing?
When I think it was like 3 or 4 different things. Shoulder.
Yeah.
I was like.
We
super
did.
compressed.
We did. So like when we first get them in, we do this. It's called a system action reaction test, where you're just testing like hip abduction, hip flexion rotation, abduction, pelvic rotation, just a bunch of different like kind of global testing, just sampling, and that rib cage basically cleared all the tests, just the compression of the rib cage. And when we looked at his posture, his left rib cage was like basically flared up, and his right was hammered down in compression. So I started I was just seeing it from the postural assessment, and then when we started doing the positional testing, I was going, this stuff's breaking down. Let's try throwing in the rib cage compression, and it was just like bricks everywhere.
Really?
Yeah. I mean, yeah. If you want to lay on your back, just I don't know if it's still the same, but bring this out. Ready, go. Yeah. I mean, you're starting to find the stuff. Oh, we just hammered you a little bit. Yeah. It's better than it was, huh? Rotate in, lift up and out. Ready, go. Are you compressing?
No.
Rotate
I'm
in.
trying to.
Ready, go. Yeah, it feels like your body's wanting to do it though.
Probably just from what we just
Yeah. Pack your left rib cage. Yeah, come back to neutral. Try and compress it without. There you go. Rotate in, lift up and out. Ready, go. Yeah. How much different does that feel to you?
Definitely different.
Yeah. Compress. Yep. Ready, go. Yeah. So, and then just for
Oh, I
fun.
think it was this one that was really crazy.
Oh yeah. Grab the table. Ready, go. Compress your left rib. Ready, go. Yeah. Just for the fun of it, compress your right rib cage. Ready, go. Yeah, ready, go. Compress your left. Ready, go. Yeah. So there's there's a disequilibrium in abdominal compression there that's totally messing up your spinal stability there. So that's transverse testing. Then we can go, let's just go like lateral. So I think we did these side bends last time, right? We were doing these last time. Yeah. So then there's other configurations of transverse testing, which are gonna bias more abdominal or more anterior tissue. So left rotation, good, you okay there? Dude, keep doing this, just to keep bringing that thing to the party. And then we can look at 2 different folding patterns, one in the sagittal plane, not the sagittal plane of his face body, but the sagittal plane of his body. So I'm looking at this folding test there, and then we'll test out of, yeah, can you stay down there? Yeah. So we'll test out of flexion. Ready, go. And you can kind of figure out a good place to put your hand. Like that didn't feel like a great test, so I might get under his body and test through, through his chest. Ready, go. There's that. And then there's that lateral testing. So this is going to be testing more of a shortened oblique externally, and then shortened. All the obliques are shortening, but we're biasing external oblique test over here. Right, hold here, ready, go. And then we can bias the internal oblique stuff if we get him over here and over here. Ready, go. Right, because that's the same side rotator with the lateral flexion. Right. So yeah, so we can go flexion, side bend, or we can go rotation, side bend, rotation, flexion. We can go rotation, side bend the opposite direction. You can test up flex, rotate left. You can test out of rotation and flexion. You can test lay on your back. These are just various abdominal tests you can do. Cross your arms, bring this knee up to your chest, pull the knee to your chest, ready, go. Crunch up, ready, go. Now we're testing more like lower half, low abdominal, ready, go. All right, we can go crunch up, ready, go. You can look at that, right? So you can crunch up again, rotate, ready, go. Go there, crunch up, rotate, ready, go. You can look at that stuff there too. So those are just getting into more advanced configurations when you're trying to tease stuff out. And then scoot back. And then you can also choose driving them into more hip flexion or more hip extension. So crunch up, you're good to crunch up. So this is going to be more of that kind of pure modality, like pull the belly in, tilt the pelvis a little bit if you can. There you go. And then rotate. Stay over your body here. Ready, go. So that's going to be like a lot of that. You feel how much low action you're getting there? Yeah. So that's another way that you can do those tests there. So that's kind of...
I remember from the... Greg you're doing the whole... I forget what he calls it.
That's called an HI screen. Yep.
Does similar
So that's a great thing to bring up. So that's gravity loaded, hip loaded, spinal testing. And so what we're thinking about doing is locking the pelvis and then moving the spine through various configurations. So like if I was going, and we called it an HI screen because of the direction and positions that the spine is moving. So how we're articulating the vertebrae. So basically we would be looking at two different configurations here. And you can do this with respiratory testing as well. That's what's really cool. Oh, we should talk about that too. But yeah, so we can look at, so this would be the I component, flexion, side bend.
Okay.
The H would be lateral flexion, sagittal flexion. Right, and so what you'll see, I know I'm going to be blocked out of here, so this is a perfect example. So that sucks for me, right? My body's like, whoa, dude. Like, you don't want to do that. That's not good. That doesn't feel great. Whereas that doesn't feel great either. So I don't like moving this way. I was thinking it might feel better. And then I can look at this side. So that feels better for me. I feel more comfortable getting there, and then here.
So first
None
one
of
you
this
kind
feel
of
very
extend
good.
back and then
Yep.
first
So
time you
yeah. So you would just, based on where your hips are, you're looking at going forward and away from that front leg, or sideways and forward, because this is where I have space to move. Whereas here, this is kind of, I mean, you're
So you just switch legs at that point.
yeah. So yeah, you were testing here. I mean, you could test here as well. It's just the protocol that he's created, goes the other direction there. Yeah, I think it has to do with the opening and closing of the facets, because I think in this situation the facets are closed here, right? Everything is already closed down here, so I have more freedom to move facets on that side, right? So here, 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 here. Then you can go there. Right, so I'm getting more movement with
Yeah.
exhalation, which
Yeah.
you would expect to see. But the problem is, why am I not moving well with inhalation? And that I should be able to move well with inhalation too. So what you can do is train what we call the systematicity training, right? Leveraging something you're good at and then layering in something you're not good at mechanically. So you could leverage something where you're going.
And then breathe in.
That feels really good. And then you can recheck it after a few reps. And let's see, I don't know if anything's going to change, but yeah, a lot better already. All right, so my brain's going, okay, we can do this now. We don't have to be freaked out about breathing in and folding down in those configurations. So, same thing with, hop on the table one more time, man. Let's just, wait, dude, that's a great thing to bring up, that HI. The same thing you could do with all of this axial, lateral, sagittal testing. Breathe in, rotate right, hold here, ready, go. You like that? Are you packing ribs there?
I don't think so. No,
Yeah,
I wasn't.
okay. And then breathe out. Ready, go. So then we could choose to train systematicity here as well, right? So breathe in, rotate, hold, stay up, and breathe out. Forced. Push, push, push. Don't lose it. Don't lose that rotation. Don't lose that rotation. Keep pushing out, 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 rest. Right, yeah. And so you could drive that if you, let's just do 2 or 3 of them just to see what happens. Big breath in, big, 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 big. Rotate, hold, breathe out, stay up. Stay up, stay up, stay up, stay up, stay up, 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 up. And rest. You feel your spine shrinking as you breathe out there a little bit?
Yeah.
Yeah. Last one more. Big breath in. Rotate, hold, good. You're falling off a little bit, stay over. Yeah, there you go. Okay, rest. We'll just see what happens. I mean,
Yeah.
but it's kind of cool to
Yeah.
feel what that
Totally.
that can feel like. Good. There you go. Good. So rotate, breathe out. Ready, go. It's a little better, but there, there's stuff, other stuff. So that's one way to play with that.
That's
You can
cool.
also go arms crossed, rotate, fold, breathe out. Yep. So you're trying to smash that diaphragm up into the rib cage. Ready, go. Yeah. So there's a brick there. Breathe in big. Ready, go.
Yeah.
Okay. Sorry. Yeah.
Okay.
Yeah. So there's some interesting interactions with your diaphragm and the way that your ribs and your spine are moving and the way your brain's perceiving
Right.
control. And
Yeah.
so we could leverage the heck out of your diaphragm. But also, what are we dealing with? We know that there's this rib cage thing going on over here.
Yeah.
That we're really targeting massive movement with the rib cage when
Right.
we're doing this respiratory and spinal testing. So, but those are great ways that you can do that. That actually, this is a perfect segue because I think the next thing we were looking at was they were talking about serratus posterior superior. So these are muscles that connect the rib cage to the vertebrae. And so this is that same idea of leveraging respiration with spinal movements. So you can also look at things on the table where we're doing extension and then you're pushing out of extension, exhalation, pushing out of extension. And then we have that serratus posterior inferior, which is going to be here. And that's a great way to shorten that serratus posterior inferior, is by getting into this hip flexion lumbar extension and then testing that hip extension or testing that hip extension. You want to feel what those feel
Yeah,
like?
sure.
Do you guys want to do? We should probably do. Well, let's do this and then we'll do.
I'll have to go in like a couple minutes. So.
Okay. Well, I think we might want to do another round of
Yeah,
spinal
I
testing
think
next
so.
week.
Yeah.
Yeah. Just 10, 15
We'll
minutes
do it.
of it.
Yeah,
Yeah.
that sounds good.
Yeah. Breathe in. Push. Breathe out. All the way, all the way, all the way, all the way, all the way. Push. Good. Nice, man. How'd that feel?
Decent.
Both felt good, yeah? Lift. Breathe in. Push. Good. Breathe out. Push. Good, man. Felt great.
Yeah.
Link arms at your sides. Lift up. Breathe in. Tuck the chin a little bit. Yeah. Come this way. Ooh. Nice pop. You okay?
Yeah, fine.
Hold. Okay. Rest down. Breathe in. Breathe out, excuse me. Lift up. Ready, go. So, there's the breathing component again, that's great. You want, we'll test these out next time. Yeah. Yeah, let's read through these. Let's check those out. Just so you can have an idea. I think this is the end of it. Yeah, then we have the intertransverse, sorry. What's that?
You should be the last two.
Yep.
pages, yeah.
Although they are sandwiched between the shoulder and muscles and the erector spinae, these two broad muscles only affect movement of the ribs. The belly of the superior is partially deep to the scapula and has fibers that parallel the superficial rhomboids. The inferior is deep to the thoracolumbar aponeurosis, and during exhalation can stabilize the ribs against the pull of the diaphragm. Both muscles are superficial enough to be accessed, but due to their thin tendinous bellies, discerning them is a difficult story. So serratus posterior elevates the ribs during inhalation, which means that it's going to depress the ribs in exhalation, or it's going to move into a depressed state as, or it's going to, what's that?
Say that again?
So the contraction of the serratus posterior superior elevates the ribs,
right.
and so on the exhalation, that tissue is going to lengthen. Is another way to think about it too.
Okay, I see what you're saying.
Yep. So if you wanted to test it in a lengthened position, it's going to be an exhalation cycle that would lengthen that stuff. Spinous process of C7 to T3. So that's going up into the cervical and covering a decent portion of the upper thoracic spine. So this is another good thing to think about is if you're seeing some kind of funky, like vertebral misalignment action up there in that, C3 or C7 to T3 region, you could leverage this respiratory posterior superior stuff and start testing there. If you keep working this stuff, you go, man, they're just not getting there. They're not getting this shortened stuff. It's not pulling the spinous process to that same side. This might be a good avenue to look into to help kind of support the spinous process. The serratus posterior inferior depresses the rib cage during exhalation. So we would be talking about, like, if you wanted to test this in a shortened position, you would be testing hip extension with exhalation. Whereas if we're talking about testing serratus posterior superior, or that subset of tissue there, we would be talking about looking at that with inhalation to shorten it, right? So, good things to think about. Spinous process of T12 to L3. So, we're talking about lumbar spine instability. This could be a contributing factor, especially if we're talking about instabilities with the rib cage, lumbar spine connection there. SP of T12 to L3, posterior surface of 9th through 12th ribs.
Sweet.
Yep. Intertransversari. These are teeny little crazy muscles. As their name suggests, these small, short muscles span between the transverse process. They are the deepest muscles of the cervical and lumbar regions, and for this reason are nearly impossible to detect, let alone access. They laterally flex the vertebral column to the same side, extend the vertebral column when bilaterally contracted. It's just the meat that keeps the transverse processes connected together.
Gotcha.
Yep. Interspinalis, same thing, except for spinous process.
Gotcha.
I think the notable thing is that some of the thoracic vertebrae do not have these apparently, which is interesting. I did not know that until just. So anyway, there we go. Cool, man. So that covers the that covers pretty much the meat and potatoes of the spine,
Sweet.
axial skeleton. So shoulder next, we'll do shoulder next week,
Yeah.
and then cover all. We'll just cover all the spinal testing again.
Big review.
Yeah, we'll do, and I think what would be cool is I'll just rattle off like test, rotation, and sagittal plane flexion, and then we'll just
Yeah.
do that. Test, rotation, same side lateral flexion. Cool. So I'll just kind of throw different planes at you guys, and we can kind of see how that plays out. Have them go supine, test lateral lumbar flexion, anchored, non-anchored, T-spine supported, lumbar spine supported, that kind of stuff. So,
Sweet.
okay, cool.
Cool. I gotta roll.
Yep.
But